On the line is Dr. Katrina Lindley. She was on last week. We've also got Dr. Scott Hardeman. He is an ear, nose, and throat specialist in St. Louis, Missouri. And Dr. Lindley is a family physician from Croatia. We heard from her last week, and I want to thank both of them for being with us. Now, Doctors Lindley and Hardeman, thanks for being with us here on the John Fredericks Radio Network. Thank you for your time.
Thank you. Thank you very much.
Thank you for having us.
All right, Dr. Lindley, it's good to have you back. I'm going to start with Dr. Lindley and then go to Dr. Hardeman, if I may. Dr. Lindley, the proposal that has been drafted by the Job Creators Network, which is healthcareforyou.com, one of the provisions in this basically says, and I'm going to be taking questions from our audience via text here in a minute, basically says that that the main piece of this is portability. That if I simply put money, I mean, this is an old school thought, but if I put money in an account over time and I lose my job or take my job somewhere else or go to another job or open my own company, I can take that with me so that I'm not dependent on some insurance company through one company or the other company in order to take my insurance. I'm not going to have to pay COBRA if I get laid off and things of that nature. Can you walk us through again how that works?
The idea is if you are in charge of your money, if you're in charge of your health care, you can have something like health savings account where you can put the money yourself and your employer can match the money, and then you would be able to choose what type of insurance you want to have. You could couple that with direct primary care, direct specialist, and really shop for your own healthcare needs. So if you're someone who does not, you're a young person, healthy, you don't need a lot of insurance coverage, you can probably choose something like catastrophic type of a plan that we used to have, and couple that with a direct primary care physician. And in most places all over the country for young, depending on the rate, but it's like $50 to $100 a month, depending on the practice. And you can have a great coverage, great health care. You can have a great relationship with your physician, and it's primarily your choice. And I think that's the most important thing.
All right,
People
so let's
don't realize.
I
was just going to say, like in one payer systems, you don't have a choice. You kind of get what you get.
Right. So you would still have choices here. But Dr. Hardeman, I want to get to you. One of the concerns that people have is pre-existing conditions. And this was a real issue. And I have to say, one of the things about Obamacare that every poll that's come out has showed that people favor the fact that if they go from one place to the next, that if they have pre-existing conditions, those get covered. But that's what drives up rates for everybody, right? Because if I'm sick, obviously it's going to be a higher rate. If I'm not paying the higher rate, that's subsidized by everybody else. Dr. Hardeman, in this plan, how do you deal with that?
Well, it's an excellent question, but I think it's important to know that in this plan, that's one of the key elements is that we do maintain the pre-existing conditions will be covered and prevents insurers from dropping patients that have these conditions. By making your insurance more portable, as Dr. Lindley was saying, it creates the ability for you to shop those around. But certainly, before the Affordable Care Act was placed, there were many states that had plans in place, state function plans in place that covered these high risk and or guaranteed coverage pools. They became moot under the Affordable Care Act because the insurance that was mandated top down from the government, unfortunately, made those plans less accessible. So we want to expand and return function back to the state to create these guaranteed coverage pools that allow for patients with more expensive conditions and or pre-existing conditions to be stratified and covered through a insurance policy that the states can develop and run accordingly.
All right, so this is kind of a state-based program, basically, where there would be kind of like a poor driver, if you will. There would be a high-risk insurance pool. Is that the way it works? Yes,
essentially, yes. I think there's, like I said, there's a number of states that had the plans already in place that were were covering patients with sort of high-risk conditions, and those became ineffective effectively. So now we can expand those and put this back in the state's hands, that the folks that are essentially cause the insurance premiums, as you mentioned, to go up when you put them into a large risk pool. You can really manage that risk better and create a mechanism to cover those conditions.
You're on the John Fredericks Radio Network. We're with Dr. Lindley and Dr. Hardeman. Dr. Lindley, a personal family practitioner, physician. Dr. Hardeman, ear, nose, and throat, among many, many other things. If I were to read both your bios, I'd be out of time for the entire segment. So just trust me, these are two very well-qualified, very noted doctors in their field, and we appreciate their time. I want to take your text questions, 757-6910, 757-692-1710, 757-692-1710. If you have a question for the doctors on this plan, we'd love to get you involved. 757-692-1710. Let's get...
May I make a comment about pre-existing condition, if you don't mind?
Yes, Dr. Lindley.
I just want to... so pre-existing condition is a word created by insurances, because when a patient signs up for me, I never... for direct primary care with me, I never once ask, what type of medical problems do you have? I never ask them, what medications are you taking? I just tell them, this is how you sign up, and I take care of them. So if you have... if we start losing this notion of these pre-existing conditions, we all have them. We all have something. So I think that's the biggest pitfall of healthcare, the pre-existing conditions. So if you do something like having direct primary care, direct care, and high deductible plans and stuff like that, and coupled with what states offer, then we are not going to have any trouble with pre-existing conditions.
How does this, let's get back to Dr. Hardeman. Thank you, Dr. Lindley. How does this really solve indigent care? I mean, one of the issues that Dr. Hardeman keep driving up the cost of a hospital stay is people without any insurance, right? Whether you go to the plan that we're talking about today or any of the other non-Medicaid for all plans, people go to the emergency room. They have no coverage. There's a law passed says they have to be cared for. They don't pay anything. That drives the cost up for everybody else. How does this plan solve that, Dr. Hardeman?
Well, obviously, you'll recall under the Affordable Care Act, it was mandated that everyone have insurance, and unfortunately, that didn't play out to be the case.
Right.
So, essentially, what's happened in that environment is that insurance, having coverage and having access to care are two totally different things. So, a large portion of the population has continued to decide to not purchase that coverage and go into the exchanges. And as a result of that, we continue to have the same cycle that you just mentioned, that they are uninsured or underinsured and present to the emergency department. The care needs to move out of those more expensive places. The overutilization of ERs in general is very high in this country and in certain regions of the country. There's plenty of waste within the system. I think we're spending about 20% of our GDP on healthcare now, and a third of that, or $1 trillion, is thought to be waste in the system. So we need to streamline this medical industrial complex so it works for the patient and try and restore that doctor-patient relationship. Once patients have more of an interaction with their physicians and more face time with them, then they're more likely to utilize their physician as a key point as opposed to the emergency department for care. But ultimately, once they make it to the emergency department, the large hospital systems, sort of incentivized through the Affordable Care Act, have really driven up costs and haven't really improved quality. In fact, many studies have shown that quality has gone down. And so we can deliver care for a lot of health conditions out there outside of the emergency department through patient education, through creating more avenues for them to make contact with their physician. But we have to restore that relationship with their physician first.
You're on the John Fredericks Radio Network. We're with Doctors Katrina Lindley and Dr. Scott Hardeman, and they're proponents of the plan that has been put forth to the White House and to Congress by the Job Creators Network. You can find that on their website, healthcareforyou.com, healthcareforyou.com. All right, I'm going to take a few text questions here, if I may, from our listeners, and either of you can answer this, Dr. Lindley or Dr. Hardeman. Amy in Fairfax, Virginia says, with Healthcare for You, would options be available to federal employees and TRICARE recipients? Great question.
I can take the answer if you want me to.
Yes.
It's a little bit difficult to say exactly what the government will mandate and things like that, but as long as there's no mandate for them to be taking the insurance through the employer, the most important thing is choice. So yes, I would hope that this would be available for everyone, and especially with TRICARE and things like that. We are trying to expand even direct primary care into the VA system and things like that. And through Mission Act that President passed, the veterans at least are able to get more health care outside the VA system.
Yeah, I think you nailed it. Right, it comes all these questions. It comes down to choice and putting patients in control of what they do. But I think what's really at the soul, the core of Amy's question, is look, federal employees and members of the federal government that are paid by the federal government, they have their own plan. So why are they ever interested in really fixing anything? Because they don't play by the same care plan that everyone else does. I think that's where Amy was going with this, Dr. Hardeman.
Yeah, I would agree with that. I think there's no reason to think that if we have expanded choice and freedom to choose how you spend your health care dollars in this country, if the federal government would allow patients to go outside of that system, then obviously these plans would be available to them. But you're absolutely right. Until we all play by the same rules and stop picking winners and losers, there's people are going to be harmed. Patients are going to be harmed in the process.
Here's an interesting question I'm going to give to Dr. Hardeman. This is from Eugene in Virginia. He says, why aren't we hearing any politicians talking about this?
Well, I think the most thing that we're hearing about currently is Medicare for all.
Right.
Obviously through the debate process, we've seen a lot of that on stage and how that's playing out. I think there's the White House has sort of started to adopt some of the language for healthcare for you. And when we went and started this process with job creators and the physicians and patient advocacy groups, we went out to market and essentially asked questions to 25,000 Americans across the country from all walks of life. And what we found and what we've heard is the key points of this particular plan are the things that people want in healthcare. They want affordability and freedom to choose. They want peace of mind in their healthcare, and maintaining coverage of pre-existing conditions. They want to have control over the spend of their healthcare dollars. We're hoping that this just creates this continuous, ongoing drumbeat from the grassroots level, and that the White House and politicians from both parties adopt this concept. You know, having been in this business for 20 years and watching the slow erosion of healthcare take place, it's not political for me, and it's probably not political for most of us. This is about doing what's right by our patients and trying to restore that relationship. So we're hoping that that politicians come on board with what we're trying to do for our patients.
And I've got a question, Dr. Hardeman, for Dr. Kat Lindley. So, Dr. Lindley, Bob in D.C., Washington, D.C., texts in and says, because you take, he calls it the monthly pay system, if Medicare for all would passed, would that put you out of business? Would you still be able to take that, or would that be outlawed? Great question from Bob in Washington, D.C.
I think we touched a little bit on this last week. In my opinion, and again, this is my opinion, because we do not have enough healthcare providers. Once Medicare for all type system kicks in, I truly feel that they're going to have to create some kind of mandatory recall of all physicians, nurse practitioners, and PAs to make us kind of provide healthcare for all the masses, because we have the population of the United States. It's enormous, and we don't have enough physicians to take care of them. So I feel that if Medicare for all is started, all the physicians, all the healthcare workers will be called in to take care of everyone. The system will fail, and then 4 or 5 years down the line, there will be the free market option that's kind of starting to develop. That's kind of what has happened if you look in the history in Britain and all the countries that started one-payer systems, even in Croatia.
So, basically, what you're saying, if Medicare for all actually passed, that it would almost start a medical black market, if you will, doctors operating on a cash basis. Dr. Hardeman, just very quickly, you say, I know you've been in business, you've been doing this for a long time. If Medicare for All were to pass, right, just Warren gets elected president or Sanders, we have a Democratic Congress, it passes $60 billion, whatever it is, it passes. What would that do to your own practice and future doctors? How do you think they'd react to that?
Well, I think there's a lot to learn about Medicare for All still, and what ultimately comes out on the other side. But we've seen this explosion of bureaucrats in the exam room with doctors and patients since they passed the Affordable Care Act, and the Medicare for All is just simply that on steroids. It's going to create more and more layers of complexity. There's to Dr. Lindley's point, I think there's a movement, obviously, through physician shortages to sort of marginalize the doctor-patient relationship and substitute other care providers, PAs and nurse practitioners into our position, and what that does to the care in the country will remain to be seen. But personally, I think that if Medicare for All passes, I think that there's going to be long lines. I think there's going to be rationing of care. I think that we're going to be we will be putting government bureaucrats in the decision-making process, where the most important people who make medical decisions should be the doctor and the patient in a relationship that they've had established for years together.
All right, another question here from Gene in Chesterfield, Virginia. He says, what about malpractice lawsuits? What happens to them? Who wants to tackle that?
Well, I'll take a stab at that. I think certainly there's a lot of defensive medicine that's practiced in this country as well, whether conscious or unconscious. I think that the whole system starts to erode when you have to see more and more patients, and your time spent with them, the ability to develop that relationship with them, slowly starts to deteriorate. There's a tendency to order diagnostic tests and things to make sure that there's nothing being missed, and effectively kind of in a spiral out of control that drives up the cost of care as well. And so medical malpractice is a key part of the reform that we'd like to see in this bill, if it were to come to pass, that it will help to bring down the cost by avoiding unnecessary lawsuits and unnecessary diagnostic testing as well.
Mm-hmm. For Dr. Katrina, Leslie in Maryland says, Dr. Katrina, you talked about last week all you did to be a doctor in the United States. Why is there a shortage of doctors in the U.S. now?
I think one of the reasons is that medical costs are the cost of medical schools are going up. When I graduated from medical school, it was $45,000 a year. Now it's $80,000 in some schools and things like that. And physicians come out with high loans, and they start working in a system. They get a little bit, disenfranchised from the system with bureaucracy, paperwork, things like that. Some of them are quitting medicine, and then our older physicians are quitting medicine sooner than they used to because of the fact that the EHR is mandated everywhere. And we spend, like we talked last week, a lot of time doing stuff that has nothing to do with patient care, but it has to do with healthcare and insurance. And when you come home and have to finish another 15 charts that you didn't finish at work and take care of your family and stuff, it becomes a burden. And like Dr. Hardeman was talking, you have to see a lot of patients. Some physicians see 40, even 60 patients a day, which is insane.
It's unbelievable.
And that's why some of us, decide to go a different route. And for us, the most important thing is the patient-physician relationship. And I think as that comes back, people will start going back into the medicine. And the other aspect is that the corporate practice of medicine, which in Texas is actually not even allowed, but it's everywhere. And corporate practice of medicine is when hospitals or large groups, like United has their clinics and things like that, they're starting to hire nurse practitioners and physician assistants for great healthcare workers, but they're not supposed to be physicians. So what happens is physicians are getting fired. Mm-hmm. There is an article, I think in Chicago, 15 physicians just got fired, and the CEO of the company, who is actually a nurse practitioner, hired a nurse practitioner to replace them. So there is a lot of dissatisfaction with physicians, but I think as we start getting back into what medicine used to be for all of us and why we actually went into medicine, there are going to be more people going in and more people being happy. I have 5 children, like we talked about. Out of 5, 3 want to be physicians. I'm not sure I want them to, but they want to do it. So if they want to, I think, there is a bright future as long as we fight for it.
All right, I'm going to give you the final word, Dr. Hardeman, and then we got to go.
Sure. Yeah, I would just add to that as well. I think the physician burnout rate is at an all-time high, and I think the corporatization of physicians into that medical industrial complex is just continuing to escalate. So I think the numbers now say that 53% of physicians are payroll physicians in general, and 70% of those under 40 are payroll physicians. And, it creates a disconnect, I think, once you work for the large hospital complex with your patients a bit, where you're working less on behalf of the patients and more on behalf of the master at that point. So physician burnout, the doctors retiring or leaving practice early because they just overburden some crushing federal mandates through reporting for quality initiatives and electronic health records. And then we don't have enough residency training programs is another issue. We're graduating medical students that are going unmatched in the residency training program. And so there's a continued downward trajectory. And I think, as Dr. Lindley said, to some degree we're being replaced or an attempt to replace the physician workforce with mid-level providers as well, which again can provide great care, but needs to be done in conjunction with physicians that have spent 5 and 7, 10 years or more getting to the point that we're at in training, trying to take care of our patients.
All right, we're out of time for this segment. Great dialogue. I want to thank again Dr. Katrina Lindley for being with us, Dr. Scott Hardeman. Thank you, both doctors, for spending your time. More information, go to healthcareforyou.com. That's healthcareforyou.com.